Hello, I would like to welcome everyone to the IBM Watson Health Executive Webinar. Today's presentation is titled Improved Outcomes from Data and Knowledge-Driven Insights, presented by Dr. Neil Jain, Senior Vice President and Chief Medical Officer of IBM Watson Health. Dr. Jain is Senior VP, Chief Medical Officer, and co-founder of Explorus, a cloud-based healthcare analytics platform company acquired in 2015, along with Vitel to form IBM Watson Health. Prior to joining the Explorus Watson Health leadership team, Dr. Jain spent 16 years at Cleveland Clinic, most recently as Senior Executive Director of IT, where he led several health IT innovations, including programs to support research and quality informatics for population health, and created interactive dashboards to monitor the meaningful use of the electronic health record. He continues to practice and teach internal medicine at the Cleveland Clinic. Dr. Jain serves on a number of advisory boards, has authored more than 100 publications and abstracts, and has given numerous talks at national meetings on the benefits of health IT. He is a diplomat of the American Board of Internal Medicine and a fellow of the American College of Physicians. Before we begin, I would like to review a few housekeeping items. First, you have a control panel on the right side of your screen. You can minimize and expand this panel by clicking on the arrow in the upper right corner. Second, you can submit questions using the question panel located near the bottom of your screen. We will try to answer as many questions as we can at the end of the presentation. Finally, all registrants will receive a copy of this presentation and a link to the recording within 48 hours after the webinar. The information will be sent to you to the email in which you registered for. And this time, I will turn it over to Dr. Jain to begin the webinar. Take it away.
Thank you, Shauna, and good afternoon, everyone. What we're going to do for the next 45 minutes or so is talk a little bit about what it means to be taking data-driven and knowledge-driven insights to the healthcare field, especially as the transformation is occurring around us. I'll first start off by giving an overview and an update, if you will, on Watson Health. A lot has happened in the 1 year that Watson Health has been formed. And we'll talk a little bit about some of the challenges that many of you are facing around the use of analytics, or especially around the use cases that are challenging all of us. We'll talk a little bit about how the ecosystem that Watson Health is creating is driving value in big data-driven and knowledge-driven insights. And then we'll finally talk about how cognitive computing can enhance those outcomes by taking some of the knowledge and combining it with the data that we see rampant in healthcare today. The first thing I want to do is give you sort of a landscape. It's been a year. On April 13th of 2015, Watson Health was formed. And as Sean mentioned, it was really the culmination of Explorus and Vitel coming together with some of the legacy companies like Curium Health that was part of the IBM portfolio. And when they formed Watson Health, meaning when we formed Watson Health, if you will, we had a simple goal, and that was to transform healthcare. And as Ginny Rometty, the CEO of IBM, put it, it was our moonshot to transform health through the use of data, through the use of analytics, through the use of knowledge, and then using cognitive computing, the Watson core platform, if you will, change the way we deliver and pay for health and the way we all experience health. And in that process, our goal was to bring together all the various members of the ecosystem, whether it's the providers, the hospitals, or the care teams that help providers manage at-risk patients, those that are managing patients at home, through a variety of different impact points. And some of those were around bringing data from disparate systems. Some of those were around driving new insights, using data, using knowledge, using augmented intelligence that we'll talk about in a few minutes. But to really focus on a few different areas, including population health and condition-specific care. And what we mean by condition-specific care is we know that when we manage complex patients, that we have to be thinking about their diabetes and their heart failure and their depression as very distinct than what we might need to be thinking about when we're talking about health and wellness. So really having our ability to bring together a whole host of different solutions to target these different areas within this ecosystem. And then the other principle that Watson Health has been it's been a key for us is that we did not believe, and we still do not believe, that we will invent every single great idea that might be out there when we think about data and knowledge-driven insights. And we want to create an ecosystem in which we can bring partners. And we'll talk a little bit about some of those partners and how they're driving outcomes with data and knowledge-driven insights. But before we do that, I do want to spend a few minutes just making sure that we cover the 5 sort of parts of Watson Health today outside of the Watson core technologies that you may have heard about from a cognitive computing or a augmented intelligence point of view. The first is Curum. What Curum does is it expands the capacity of Watson Health to help the public sector, the public health sector, cities and social programs find ways to more intelligently and efficiently assess the eligibility that members of the community might have to different programs, and then to maximize those results. So Curum would be found in a variety of different health and human services components across the country and in many other countries. And that has been a part of IBM for several years. And in bringing that together with Exploris, which has been focused on complementing and strengthening the Watson Health Cloud platform through bringing data together and a rich ecosystem of clients that range from large integrated delivery systems all the way to clinically integrated networks to narrow networks. And also be able to take that information that comes from all these different health systems and make that data available to drive net new knowledge discovery. For example, much of the data that is part of Watson Health today fuels publications that are happening on a weekly basis and many that are changing the way we might look at certain outcomes in health. Phytel is a very familiar company to most of you, and they are able to help bolster the ability of Watson Health to apply advanced analytics to help primary care providers and specialists in large systems as well as small practices engage with patients to improve their overall health through automated outreach and through very complex care coordination strategies. Merge Healthcare is an organization that was acquired by IBM this past year as well that has been focused on imaging informatics and really helping analyze and bring together the rich data that an image contains and marrying that up with the clinical histories to drive better diagnoses and a better experience for the patient and for the providers who are reading the radiology images. And then also leveraging the Watson Health Cloud to make the storage of images much more efficient and the cognitive computing to help understand what those images are telling us about a patient's overall health. Finally, one of the most exciting developments over the last several months for IBM Watson Health has been the announcement that we were intending to acquire Truven Health, and then the actual closing of our deal with Truven Health and the acquisition about 10 days back. And what we did was basically bring together Truven Health into the population health portfolio to help us understand when providers work with employers and with health plans to take on risk, can we create an ecosystem by which Truven Health's experience with the and with the employers can add value on the data-driven and the knowledge-driven insights point of view to help our mutual clients really solve some of the biggest transformational challenges in healthcare. After all, providers are beginning to take on significant amounts of risk. They're beginning to have the same challenges that payers have had. And employers are looking for ways of helping drive efficiencies and reduce costs that their employees are bearing and that they themselves are bearing for carrying on risk. So we're really excited about the ability for Truven Health, who bring 8,500 clients to the Watson Health portfolio, expand their role in population health within IBM Watson Health, and also to create new offerings that are going to leverage the clinical data expertise that Exploris and Phytel have had with the claims and administrative expertise that Truven Health has had. Now, we know that if you are a healthcare provider today, there are 3 main forces that are asking you to change the way you do business, or the way that you manage your interactions with patients, or the way that we might get compensated for care. And by the way, I still see patients part-time at the Cleveland Clinic, and in many ways, what we're seeing, and it's sort of really pressure from 3 different directions. One is a significant amount of pressure to re-engineer the way that we deliver care. Another is re-engineer the way that we get reimbursed for that care. And the third is to survive while we go through all that transformation. The surviving piece comes in from coordinating that care so that we tie in the reimbursement to the actual delivery models themselves. And we'll talk a little bit about how data-driven insights and knowledge-driven insights can sort of help us deal with this transformation. The first thing we want to start with is a very sobering fact that many of us who have been in healthcare have recognized over the years, is that about a third of the healthcare that's delivered can be categorized as waste. This is a report that came out of the Institute of Medicine that looked at the sort of the services and the care that patients were receiving and tried to figure out what was adding value to that patient's experience, to their overall livelihood, to their overall health, and what was not. What was the inefficient pieces or the waste pieces? It's a third. So we should be able to make an impact on that. That's a significant amount of opportunity. So we all know about the triple aim, but how do you go beyond the triple aim? The triple aim has traditionally been characterized as looking at the overall cost of the care we deliver, maybe looking at it at the patient level, but also at the population level, looking at the quality that we deliver, the quality of care, meaning that we cannot just simply reduce the cost if we leave quality behind. We have to do both at the same time. And we have to look at the way that our patients experience that particular care. It's one thing to improve quality and to reduce cost, but we need to make sure our patients are engaged with the way we transform that care. And then finally, when you go beyond the triple aim, we sometimes think about it as the quadruple aim, we have to think about the welfare of the providers who are increasingly looking at their role in the healthcare delivery system and asking themselves whether their jobs are becoming easier or harder, or whether they're even making a difference. So we got to make sure, and in Watson Health, we're looking at the overall experience of the patient as well as the provider. We simply cannot put technology in front of a provider for the sake of technology, but we have to find ways of making their processes easier and more effective. Now, one of the evolutions, at least in the US, that providers are having to try to decipher and make better sense of is some of the regulatory changes that are coming about. And as we think about MACRA, which is think of it as the latest reform or program enhancement to Medicare, if you will, it has a series of requirements that are going to force providers and those who serve providers like ourselves to think about how we can help the health systems navigate around some of the challenges that they're going to have, whether it's about an alternate payment model like bundled payments or global payments or some sort of shared risk model, or whether it's on how they get incentivized to present themselves as physicians who are looking out for value-based care and driving quality and at a lower overall cost and reducing avoidable complications. And so I'm not going to spend a lot of time on macro here. I'm happy to take some questions on that later, but these are some of the challenges that we are dealing with, and you have to use data-driven and knowledge-driven approaches to fundamentally win in an environment in which there is significant regulatory pressure. At the same time, our margins are being squeezed, and at the same time, we're being asked to know a lot more about healthcare than we've ever had to. And I'll explain a little bit of why that's a bit of a challenge if you don't use knowledge-based insights. Now, we also understand, and the experience that we've had with our clients is that every client is at a different stage in their journey towards a complete transformation to driving quality at a lower cost with great patient experience and great provider experience. Everyone's on a different spot depending on their environment, depending on their payer mix, depending on their preferences for what they would like to do within their communities. And we want to make sure that we articulate that a data-driven and a knowledge-driven approach can improve outcomes regardless of where you are on the spectrum. It's just simply a matter of making sure that you are able to create a path for that change and then use the data and knowledge-driven insights to get you where you want to go. One of the biggest challenges, and this is a study that was published by KPMG about a year ago, and what they found was that just 10% of healthcare organizations are using data and analytics. Now, clearly, for those who are attending this webinar, you are probably some of the believers that data and analytics and insights can actually solve the healthcare paradigm. But most people out there, if you're in a large organization, many of the smaller practices that you may want to align with or consolidate with probably haven't got the same focus on data and analytics, because it is truly complex, as many of you know. But only 10%, which means that we have a huge opportunity to help bring our colleagues along and get them to understand. And it's not just the providers and the leadership of these organizations, but it's those folks who are truly taking care of the patients, the nurses in the hospitals and the nurses in the care management programs. They also need to understand, he or she need to understand that analytics are a partner for quality improvement. You need to do both. And as things get more and more complicated, you're going to have to use knowledge-based insights along with data-driven insights. And I'll explain why in a minute. Now, many of you are facing some of these obstacles to adopt analytics in your organizations. Some of you may be customers of Vitel, Exploris, IBM Watson Health, and have already gotten some help with the ability to get the data and to share that data across the ecosystem to those who need it and those who can make a difference with it from a regulatorily compliant way. But there's a significant amount of emphasis on some of these challenges, and when they've done surveys of folks that are running ACOs. So back in 2014, a survey showed that more than half the folks found significant challenges, and we'll talk about some of these. Interoperability. So the Office of the National Coordinator has been pushing for interoperability of electronic health records and healthcare data for some time, and we are still working at it. So today, we may have a glimpse of technical interoperability, but we certainly don't have semantic interoperability. When we are managing patients, we don't have that expectation that our medical information will just translate to another care provider seamlessly in a meaningful way. We worry about it, and our solutions are helping chip away at some of that anxiety and concern. We worry about whether we're going to have money to do analytic projects. And if we do analytics and try to bring insights, how does it integrate into the workflow of the providers and the care teams? And then, are the docs on board? Are the care teams on board? Have we convinced them that transformation is real and that technology is an enabler? It's not the only answer, but it's an enabler. And then, of course, change. Everyone in healthcare in general has had to use a number of applications. Think about the electronic health record. Now they need to be trained on yet another system. So there are lots of challenges, but with each of these challenges comes opportunities. And let's talk about some of them. And by the way, this is in a 2014 survey. A year ago, there was a 2015 survey done by Deloitte Center for Health Solutions that showed, again, very similar findings. So although we are making progress as an industry, one of the things that I think many of you have probably faced when you're in boardrooms or you're in meetings is that the culture and politics in healthcare systems are not necessarily fully aligned with the transformation that's happening around aligning community practices with large hospitals. And so there's work to be done here, and we all play a role in trying to get past this, because the true value of data-driven insights and knowledge-driven insights is when you can get the right information in front of the right person in the right place. And that may not be in the four walls of a hospital. It may be out there in the community. One of the things that Exploris was a pioneer on, that we have brought to Watson Health, was our ability to think about big data in the healthcare context. And I want to make sure we define big data. And now our ability to take that big data and push it over to folks like Vitel, who can then engage with patients, is a cornerstone of some of the value that we're going to be talking about. So let me describe what it means. So traditionally, big data has been described as the 3 V's: volume, velocity, and variety, meaning data is coming at us. A lot of data is coming at us very fast, and it's all coming at us in different shapes and flavors. Those are the traditional 3 V's. But IBM, Watson Health, we have a 4th V, which is the veracity. Many of you who are providers who have been on the receiving end of a report about your performance or your practice's performance, if you don't believe the data, you don't believe the insights, it's really, really tough to make change. So veracity is incredibly an important V when it comes to big data. And we'll talk a little bit about that in a minute here in terms of how we make sure that we get not only the right data in front of people, but we also make sure that we're able to do it in a consistent way. Now, the Watson Health Cloud, you may have heard about this. Watson is sort of a cognitive, augmented intelligence type of engine. It's, you recall back in early 2011, it was the computer system, if you will, that beat Jennings in Jeopardy. That's shortly after that, the Watson research team was having conversations with healthcare providers across the country, trying to figure out how we can solve healthcare. But what Watson Health Cloud is simply a new paradigm for thinking about how do we leverage the power of the cloud with all the security and safety that we have these days, with the ability to help people bring data to the cloud and then be able to leverage solutions that help them draw out insights. That's the way we should be thinking about the cloud. And we should be thinking about it as not only IBM Watson Health being in the IBM Watson Health Cloud, but our clients being in there, our partners being in there, and driving value from there, and our patients being in there, or the consumer, or the health plan member, or the employee of an employer. These are all constituents that can take advantage of what can happen when you bring a bunch of disparate data together and then draw out insights towards outcomes that we desperately need to have in healthcare, which is to make healthcare much more efficient, avoid complications and avoidable costs. Things that healthcare providers won't get paid for in the future, we need to start avoiding those today. So what does this platform look like under the hood? If you were to take the cloud and peel away the layers, what does it look like? Well, it first starts with the ability to gather that data. Remember one of the challenges I mentioned earlier, getting the data. So let's get the data from the EMRs. Let's get the data from the different silos of health data sitting in practices and in hospitals. Let's get the data from the payers that have claims that happened with care that happened across the ecosystem from all the different venues of care, whether it's a standardized bill or if it's a unstructured document that we can use Watson natural language processing to help decipher. Let's bring it all in. Let's bring it all into a data lake. And in this data lake, we start organizing the data around each and every single person. And we start to curate that data, meaning we clean it. We make sense of it. We standardize it so that we can start bringing some semantic interoperability into the mix. We make sure that Mr. John Smith, who walked through the emergency room door, and Mr. John Smith, who saw a cardiologist in the community 2 weeks later for follow-up, we can match their records together. And let's make sure we can search across that data very, very quickly so that we can start doing risk and prediction for risk identification. We can start understanding their gaps in care, and we can start throwing them on work lists so that care managers can more efficiently reach out to them, or put them on a work list for automated outreach through Fitel's tools. Get them into a care management program if they're diabetic or have heart failure, or maybe they have both. And make sure we do this in a regulatorily HIPAA-compliant way. And we have lots of demand for different types of solutions, whether it's population health analytics or patient engagement or care management, or one of my favorite areas is that we typically do what we know to do, but we also got to make sure that we're continuously innovating through our life sciences and through discovery of what works. So we shorten the cycle between the bench to the bedside to the bottom line. So these are all things that can happen when you start bringing data together with different pieces of knowledge. Now, what does a descriptive sort of set of analytics look like when you just use data? With data alone, we can start to identify what a population looks like. Where do they live? How far do they live from their practices and from their hospitals? What's the disease burden? And how does it compare with a known quantity of population? So these are all things that a data-driven approach can give us visibility. And some would argue that much of this visibility doesn't exist in healthcare providers today. Many of us go blind with some of our risk-bearing contracts. We're asked to manage a set of patients, and we do so without some of the basic descriptive analytics, data-driven analytics that we need. But you can go further. You can start talking about the ability to predict risk. So you can start putting patients into different risk bins. low, medium, high, and then apply the appropriate amount of resources against those particular areas. What can happen when you bring a lot of data together is that you can start to create risk models that are fundamentally better. So instead of predicting 30% of the risk, maybe you can predict 70% of the risk and identify that Mr. John Smith, who is likely to be readmitted to the hospital with heart failure because they have significant comorbidities, and there are system factors that weren't adhered to when they were discharged. Things of that sort. And the performance, which we can spend a little bit more time on later, the performance of these models is going to be better because the performance of predictive models generally is about science and math. It's about the statistics of bringing a larger set of data points and getting the model to predict a higher amount of variability with more and more data. Then it's about the science. If you use more variety of data, going back to big data, if you use more variety of data, like not just demographics and diagnoses, but procedures and medications, you're much more likely to have a much more predictable set of analytics that's going to help you identify those patients at risk. And this is some work that Milliman did with Explorers, where we showed that our risk model did well, did very, very well for lots of good reasons, including the fact that we were starting with a very large or big data paradigm. Now, what can you do? When you have a risk model that helps you risk stratify, you can take that and start to marry that up with some of the resources that we have available for care management and outreach. So those resources that are actually going to create outcomes when you have data and knowledge-driven insights. You can start to have a much better understanding of what your population's risk factors are, and therefore maybe have a much easier time contracting at a rate that makes sense to the plan and to the provider organization. The other thing you can do is you can start bringing in clinical data and marrying it up to claims data. So showing that the cost of a diabetic who's poorly managed, of their A1C being greater than 9%, is actually higher than those diabetics whose A1Cs might be representing well-controlled diabetics. So the ability to look at hypertensive patients with blood pressures out of range versus hypertensive patients whose blood pressures are in range, that requires the ability to aggregate clinical and claims data together across the ecosystem when payers and providers come together in a shared risk or shared savings contract. These are all things that you can do, and then you use data-driven analytics to drive these insights. At the end of the day, though, it's not just about finding things, it's about actually making it actionable. So here's an example of a dashboard that a provider can see that shows trending and has the ability to give them some highlights of where the overall risk is, helping them understand that their performance at the population level can be translated to a patient level if we're able to use risk scores to identify a variety of risk, and then getting them to do the right thing for the right patient at the right time. But what about the patient? So the patient, from a patient engagement point of view, we need to identify which patients we need to use the most expensive resources and which ones we can do some automated outreach. And Explorers, working with Phytel and Curum and the rest of the Watson Health portfolio, we can take those data-driven analytics and push them across and do a smarter patient engagement, a smarter care management. Because at the end of the day, you have to start thinking about what is it going to take to manage those patients in order to reduce their overall care, improve their quality and experience, and drive value to the person, the patient, the employee, the health member, but also to the ecosystem as a whole. Now, one of the challenges we have is that all the data we just talked about, those clinical factors, in some studies shows that it only represents about 10% of a person's overall health. What do I mean by that? Well, our clinical factors, your blood pressure, your weight, the fact that you have diabetes, those data points are not enough. We understand from a personalized medicine approach that 30% of a person's overall health comes from your genomics and protein expression. Another 60% comes from exogenous factors, meaning where they live, where they work, what's their socioeconomic status and their educational attainment. What do they do from hobbies, recreational activities? Do they have access to providers, to parks, to police? And what's their overall experience? Are they engaged? Are they activated? So that's the vast majority. So how how do we actually bring that into the fold? And so there's we're going to have a little bit of a conversation now on most of us that were trained as providers, we only dabbled a little bit in this. Fortunately for us, bringing Curium together with Phitel combined with Explorers, we have a lot more experience with some of this. And now with Watson, we have the tools to actually make sense of it. So many of us would sort of describe our experience of seeing patients and using any modern enterprise class EMR as being data rich, information poor. We have to go through a lot of data to figure out what's happening with the patient. And if there's only a way to bring the most relevant information out to me instead of me having to dig for that. It's not a knock on the EMR, it is just the nature of what the purpose of the EMR is. What's even more sobering is that, and by the way, I'm a primary care doc and internist, it is mind-boggling to think that medical data is going to double every 73 days. And it's not just the medical data that the patients are generating, it's also the literature. It's also the number of articles in the journals and textbooks. And if you read the lay press, which most doctors have to because their patients will ask them questions about it, there's a lot of stuff out there. So how do we get a handle on that? We have 16,000 hospitals worldwide that generate data through electronic means on their patients. We have significant amounts of that data sitting in unstructured forms. It's progress notes, discharge summaries, dictations, and etc. It's not in neat, tiny boxes on an EMR screen. It's unstructured. It's narrative. And that's really hard to. For some of you that have been involved with data analytics, it's hard to get at that. So we need to be able to think about cognitive computing, natural language processing, and so let's get into that a little bit. So what is a cognitive system? So a cognitive system is one, first, that is able to generate a hypothesis and evaluate it. For example, does my patient have sarcoidosis or do they have asthma? The ability for the system to say, my hypothesis is going to be that this particular patient has asthma because they have wheezing, or they don't have sarcoidosis because their X-ray was normal. That ability to do that without a human being telling the computer system and programming them how to do it is cognitive. It learns, it reasons, it evaluates. So it throws out a whole bunch of hypotheses and very, very quickly tests them. That might be familiar to many of you who do research. That's what we do in research, but we do it very slowly. And what Watson is able to do is augment our ability to do that by very, very quickly sort of simulating what we go through on a regular basis. And it does it in a much more accelerated way. It adapts, and most importantly, it really understands the way we need to be communicated to. So going back to that unstructured document, that progress note or that discharge summary, Watson can read. It can understand what's written in English and a couple other languages. And it doesn't have to have me going in there and retyping everything into small, tight boxes. Now, there is a difference between data-driven and knowledge-driven insights. And I alluded to this in a few minutes back, but we have a lot of medical records, medical literature, clinical guidelines. There's thousands of them. If you go to the National Guideline Clearinghouse website, thousands of them. And no one doc can be on top of it. No one care manager knows the latest and greatest way of managing every condition that they might deal with. Even textbooks that try to summarize this, we have a gap because textbooks are periodically updated. We miss things. So on the knowledge-driven insights point of view, Watson is able to go through all that content. It reads 18 million pages a second. It's able to go through all that and try to, again, draw out hypotheses. On the data-driven piece, which is very complementary, there is no knowledge versus data-driven insight. It's both. On the data-driven side, we have to start thinking about all the data that's being thrown off. I'm wearing an Apple Watch right now, and it is generating hundreds and thousands of data points. And frankly, my doc doesn't want to receive all that information to see how I'm feeling. They want it to be summarized. They want it to be analyzed. They want it to be combined with other insights. And they want it, the docs, we typically want it, we want sort of the exceptions and the outliers, and we want to know what it means. And as wearables get more and more rampant, as we get implantable devices that are throwing off a lot of data, we need to find a way to make sense of all that, because otherwise we'll have data-rich, information-poor situations at the bedside. We also know that there's a lot of community-based data out there, like the weather data, which is one of the most interesting aspects of Watson buying the weather company, is that we're able to now think about, what does the weather have to do with health? Is an asthmatic more likely to go to the emergency room when the air quality and the weather, can it be predictive, for example? So there's a lot of data being generated. Our partnership with Apple and with Twitter and with others that are generating social media data and exogenous data through HealthKit and ResearchKit are examples of where we will need a cognitive computing agent like Watson to draw that data insights when the data is just too voluminous for us to make sense of. And then be able to, again, draw out multiple pathways to hypotheses and test them very, very quickly. And maybe even present them in a visual way so that we as humans could very quickly understand what's working and what's not working. And keep in mind, no one is talking about artificial intelligence here. We're not talking about a computer taking over the role of a doctor. We're talking about augmented intelligence. Just like I would never walk into a room without a stethoscope and diagnose a patient having an exacerbation of heart failure without listening to their lungs and their heart, I believe in the future we will never make a complex diagnosis, or maybe even a straightforward diagnosis, without having some augmented intelligence helping us along the way. We know that we're fantastic. Humans are fantastic, maybe except for maybe teenagers. We're fantastic at common sense. We handle dilemmas like we're faced with on a daily basis. Morals, compassion. We have a vivid imagination that has created significant amount of innovation. We have the ability to dream and to think about things in an abstract way. And we also have the ability to look for patterns and generalize. Much of healthcare and much of being a doc is generating patterns and a database of patterns in our heads, seeing healthy people, seeing sick people, and generating all that. But we tire. We need sleep. We have trouble sometimes separating what we've experienced from what the evidence is telling us. An example is that if a doc has a very tough time with a case, like let's talk about maybe a kidney stone patient that they might have missed, every patient that walks in with back pain, they're going to rule out a kidney stone. We have trouble separating out our experiences from what should be done. We have difficulty with bias for lots of reasons. And so what a cognitive system can do is it can help us deliver better decisions by taking some of this other stuff out that is hampering and hindering our decisions from an efficiency point of view. Again, not artificial, but augmented intelligence, AI, augmented intelligence. Now, what's an example of it? So recently, just a couple days back, IBM Watson, we announced that IBM Watson is teaming up with the American Cancer Society to pit cognitive computing against cancer. What do we mean by that? Well, there are significant amounts of data sources around cancer. And as a cancer researcher, you start to create areas of expertise. But the American Cancer Society wants to look across cancer. And they want to make sure that they can help every one of their constituents, the patients, the doctors, and the community, really get the biggest impact from all those insights, whether they're clinical trials, whether they're publications, or whether they're experiences that patients they've tweeted about or that they've posted on social media. They want to make sure that we're able to deliver the best treatment for each and every cancer patient. You can't do that by having one person try to know everything that's happening in health. You need a cognitive system. Now, what are some other examples? Well, we talked a little bit about Apple, Twitter. Under Armour is another example of a partner that's helping us recall about the big data, the large volumes of data, recall the part about 60% of health determinants being exogenous. They're helping us make sure we can get all that exogenous data. We are helping them put it in a place, the Watson Health Cloud, that can make it easier to draw out data-driven and knowledge-driven insights. The American Heart Association. So we're combining much of our capabilities within Watson Health with the American Heart Association's employer workspace and consumer health assessments And the goal being a common goal, which is we want to help transform health, in this case by reducing cardiovascular disease. There is no doubt that much of what we clinicians have been used to in looking at cardiovascular risk will undergo significant transformations as we learn more about what those 60% exogenous factors tell us about health. Keep in mind that most risk calculators for cardiovascular health are only looking at those 10% clinical factors. And we've already agreed that those clinical factors are only 10% of the health determinant. So we got a long way to go. And our relationship with American Heart Association is going to help us get there. CVS Health. Many of us think of CVS Health as the neighborhood pharmacy, and we also know it as our PBM for many health plans. But they are a point of care for millions of Americans. And working with them, we are trying to understand how we can take those cognitive insights, those knowledge-driven insights, combined with data-driven insights, and change the way that CVS Health what role they may play within a patient's health and health care. Help close care gaps, help identify adherence to drugs, for example. And we know, for example, that patients who are more adherent to their insulin have better diabetes outcomes. We need all the help we can get to get the patients engaged and towards a path of greater adherence. And frankly, we need to get them more engaged at the places in which they feel comfortable and that they frequent frequently, which would be their neighborhood pharmacy. Medtronic's another example where we're leveraging very powerful analytics along with our knowledge-driven insights through our computing platform, cognitive computing platform, and combining it with diabetes, where patients with continuous glucose monitoring and the ability to start predicting what a personalized approach to diabetes management. If the past 10, 15, 20 years has been about evidence-based medicine to drive population health and to drive evidence-based guidelines that serve the masses, the cognitive computing era is going to be about taking that insight and personalizing it down to the individual patient level, and then developing the tools, whether they're within Watson Health or outside of Watson Health, to really make sure that every patient is offered the best treatment and best care experience that they can get for their set of conditions, whether it's diabetes or heart failure or depression. We announced a relationship with a company this morning where Watson Health Cloud will be powering their cognitive platform to help engage on behavioral health issues. It's a platform designed for those who practice behavioral health, and it is really a way for us to start thinking about some of the other capabilities that cognitive has, the ability to understand personality, the ability to understand by reading someone's writings, their educational level, or their ability to engage and at what level. Wouldn't it be nice to know that before you reach out to a patient through patient engagement, what would motivate them, so that we can have smarter engagement? And from a outcomes point of view, it is critical. It is critical that we make sure that we use every tool in our arsenal to optimize the way we reach out to patients, because the amount of reimbursement in healthcare isn't going to go up, and that we are being asked to do more and more. So we got to find ways to improve the way we deliver it. Now, it's not just me saying this. The IBM Institute for Business Value, a very respectable group, did a study where they looked at and surveyed healthcare providers and basically tried to get a sense of those who knew what cognitive computing was, how many of them felt like it was part of their future. These are healthcare executives. And in fact, 95% of them felt that cognitive computing was such an important part of driving data-driven and knowledge-driven insights that they felt they were going to invest in it, whether it's through relationships like Watson Health or their own projects that they were engaging on. 84% of healthcare executives that were familiar with it believed that it would have a very disruptive role, and certainly Watson Health believes that. We describe it as our moonshot. And 81% of healthcare executives believe that it had a critical impact on the future of their business, meaning that this is something that was going to change. As much as, in many ways, the folks that I've spoken to think of this as something that is going to be as transformative as the way that the early days of order entry or getting laboratory results automatically, or getting automated testing for antimicrobials. All those things that we take for granted today, cognitive computing is heading in that direction. And the question is, will we be ready, and will you be ready? In terms of some concluding thoughts, we know that healthcare is undergoing a significant transformation. It's not just about the way we're delivering care, but the way it's being reimbursed. And we know that every stakeholder in the healthcare ecosystem is being squeezed. And the question will be, how do we make sure that every stakeholder sees value in that process, especially the providers who have that deep relationship with the patient. We are also going through a lot of consolidation and alignment, and what that's doing is it's creating a lot of disparate information systems that need to work together. We have significant advances in digital engagement and personalized medicine, as we spoke of, and because of that, there's a lot of big data being generated. What are we doing about that? And then we cannot simply make it about data. It has to be about actionable insights that change behavior. The provider, the patient, they both need credible information that's going to motivate them to change their behavior. And that's going to require us to focus on both data and knowledge. And we think about the triple aim, we talk about the triple aim, but I believe that you are not going to get the quadruple aim, the experience that the provider's having, without having some sort of assistance, some sort of cognitive assistance or augmented intelligence that's helping them along. It's going to change the way that docs who are already overburdened by the information that they have to keep track of, how it's going to make it fun again, if you will, to start thinking about diagnostic dilemmas now with an assistant at their side. So with that, I'd like to finish up and make sure I leave enough time for a few questions. Sean, I don't know if we want to go ahead and if you got some questions that you want to bring up. I really appreciate the attention of the group, and I hope that we'll have some stimulating conversation for the next 8 to 9 minutes.
Yeah, at this time you can submit questions using the question panel located near the bottom of the control panel. We'll take some time to answer as many questions as we can. We'll just take a minute to let the questions come through in the queue. I do have a couple questions that already came through during the presentation. The first one is, how will cognitive or knowledge-based insights improve the provider experience? Well, I sort of began to allude to it near the end of my conversation with you folks. Imagine you have a complex patient who is looking for the best treatment for their diabetes. And the number of new drugs that come on the market is staggering. They all have different pathways. They all work on different mechanisms of action, and they all have a different side effect profile. So one way that I think cognitive computing will improve the experience of the provider is that the provider, who is typically today very used to prescribing what they're comfortable with prescribing, will all of a sudden be able to find it more comfortable to prescribe something that a cognitive computing engine or a augmented intelligence engine like Watson is helping them pick the best medication for the lifestyle of the patient, given the side effect profile and given perhaps even their health plan information and given the impact that that particular medication might have on the constellation of disease as opposed to that one particular disease. So I think it will help us be better prescribers without having to have the anxiety of not knowing everything we need to know about every drug out there. That's a common complaint that most providers have, is that there's just too much information out there. Another area that will help enhance the experience is that many clinicians today spend more of their time hunting and pecking for information in the electronic medical record than they do talking to the patient. Imagine you could bring a solution together, like our EMR assistant solution, that distills or summarizes all the information from all the different aspects of the medical record and brings them into a single view for the provider to be able to see. And they'll be able to react to that because the most important things have been
pre-selected for their review. So again, it's very much about the experience that providers have trained for and what they really want to do, which is focus on the patient as opposed to focusing on the technology. Going back to one of my comments earlier, cognitive computing is about helping the provider or helping the user communicate and interact in a way that's natural to them. An electronic medical record for many providers is not a natural way to interact with a patient or with the system. That's why a lot of providers feel more comfortable on pen and paper until they need to gather the information and they go to the EMR. So I think it's going to fundamentally change the experience of providers.
Great. We have another question that came in through the queue, and that is, what are the plans to apply Watson Health outside of the U.S.?
So Watson Health, through their components, through their constituents, already operates outside of the U.S. today. So, for example, Curum has solutions that are in about 18 different countries. And again, because of their profile helping social programs and health and human services style, many of these countries that have a public health system, Curum has solutions for them. Another example is Truven Health. Truven Health operates in other countries today as well. When you think, as well as Merge, if you think about Explorers and Fitel, there's a path that we'll be embarking on to drive our solutions to other countries. And we have to look at three things. We have to look at the localization of what it means to solve the healthcare challenges that those environments are having. It also means that we have to understand the way that care is delivered and reimbursed, and how do we integrate into the workflow of these different these different environments. And the third one is there's a regulatory concern in healthcare that every country is a little bit different. So Watson Health has I believe, a very sound process and strategy, and there will be more to come. But you will see us in other countries in the near future.
Great. And then another one is, what is the return on investment on knowledge-driven insights?
Well, it's a great question. I think when we think about a return on investment, it implies a couple of variables. It implies, what's the cost of us doing this, and what's the value that we get back. One of the things that I got into a conversation with someone from the media not too long ago at a conference, and I got asked that question. How much does this cost for people to do this? Well, one of the things that we'd like to do at Watson Health is do much of the heavy lifting for our clients, for the consumers, so that we take the cost out of the ROI equation in a sense. We sort of build a single cloud-based platform. We build a Watson Health cloud so that everyone else doesn't have to build a platform for cognitive computing. What we want to do is we want to have our clients and our partners focus on adding value and extracting value from that cloud. We want to build that cloud so that the ROI equation becomes lopsided. It becomes all about the value that we get from when patients get better treatment, when we start to reduce the avoidable care that happens in healthcare, when we start thinking about the provider's overall comfort level with giving the right advice to the right patient at the right time, instead of wondering whether they caught up on the literature and the journals from the prior week and were they going to prescribe the right drug for their patients. So the ROI for cognitive computing is really for the clients and for the folks in the call should be about the transformation that's going to happen, and let us worry about the investments in the cloud and the computing infrastructure in many ways. That I think that's how we address the ROI.
Great. Here's the next question. What mechanisms do you have in place to measure whether or not these cognitive enhancements outcomes locally?
So one of the things that we touched upon a little bit is that cognitive computing and knowledge-driven insights is based on literature. It's based on what's been out there. And one of the sort of the bookends for that, the other bookend is that you have to then learn from it. So you have to be able to take an action or to get someone to take an action, and then look at the impact of that action, and then feed it back into itself. So it is our full expectation, working with our clients, working with our research colleagues within both our Watson Health group and then our newly formed colleagues through the Truven Health acquisition, and those data scientists and researchers at Phytel and Explorers. We will develop that evidence and those outcomes in a methodology that that health IT in general has not seen a lot of, and that is a cornerstone for how we deliver value in the cognitive computing and the knowledge-based insights world. After all, many providers need evidence before they change behavior, and we understand that. And so there are many pilots going on right now.
Okay, next question. Will or is IBM working with EMR vendors to bring these insights to create better data collection systems that generate better data?
Well, that's a great question. I think there's two parts to that. So first is, are we working with EMR vendors? And the answer is yes. We have put an announcement that we are working with Epic, for example, at Mayo Clinic, helping with a sort of a better way to do decision support for clinical trial recruitment. Understanding, for example, which patient might be a great candidate for a clinical trial. Keep in mind that even in fields like oncology, where exposure to a protocol or clinical trial is a quality indicator in many ways, many patients across the country don't get into clinical trials that they should for potential life-saving treatment. So that's one example where we're working with an EMR vendor to help bring cognitive insights at the point of care. But I think the other part of the question was to collect data better. Well, I think what we are doing today is thinking about the unstructured documents that may reside in an electronic health record that most docs have to pour through lots and lots of these in order to arrive at some of their decisions. Can we simplify that process? So we are working on some EMR agnostic, meaning non-vendor dependent solutions that summarize EMRs and bring that information forward. One of those is the EMR assistant that we are working with several health systems across the country. And there's more to come. But in terms of better ways to collect the data within an EMR, I think that entire area is going through some transformation. We know that, for example, there are many pilots for natural language speaking and dictation that are driving data into EMRs. We also know that there are many smart forms and smart ways of navigating through a patient encounter. So we're obviously working very closely with EMR vendors when appropriate and looking through all those different use cases. But again, going back to that quadruple aim, this is about the provider's experience as much as it is about driving value for the patient.
Okay, we have about 1 minute left, so this is the last question. Is what do you see are the challenges to getting care teams to adopt cognitive computing?
Well, I think one of the challenges is something that I alluded to early on in the conversation. Is they have to believe the underlying data that's driving the cognitive insights. If you don't believe the data, then whatever conclusions you draw from it are going to be, you're going to miss them. We're not going to change our behavior based on it. So I think one of the challenges is getting care teams comfortable that we have the data that represents the care of their patients. The second one is, where do you deliver that insight? Where is it within the workflow? When do you do it? And much of that is, and we have a lot of, at IBM, a lot of design thinking that goes into some of our solutions. And we work very closely with our clients to understand, when is the right time to do this? And to give you an example, many of the folks on the call today who use an electronic medical record know about alert fatigue, where a pop-up comes up and we tend to ignore them because it's generally not the right kind of, the timing may not be right, or the content may not be appropriate for that particular context, or there might be too many of them that it's not clear what's the most important thing to do. So the challenge is, how do we take a bunch of insights that a care team might need to have and how do we make sure we deliver it in a way that makes sense to them so that's actionable. Again, we don't want too much information. We want just the right amount. And that's going to be tricky. But we're working very hard at it with some of our clients.
Perfect, and that's our last question. We're at the top of the hour, so I would like to thank Dr. Jane for his time today. As a reminder, you will receive a follow-up email that includes this presentation and a link to the recording within 48 hours. Also, please take the brief survey when you log off the webinar to help us learn more about what was effective and what we can improve on for future webinars. Finally, please join us on Thursday, April 28th for the next executive webinar series, True Patient-Centered Care, Integrating Behavioral Health and PCMH Practices. We will provide more details and the link to register in the follow-up email. At this time, the webcast is ended. Thank you for attending and have a wonderful day.